Welcome to the inaugural IPNA-ISN-KDIGO webinar. This webinar will address contemporary management of steroid-sensitive and steroid-resistant nephrotic syndrome. I'm Michelle Denberg, a pediatric nephrologist at the Children's Hospital of Philadelphia with a longstanding research and clinical interest in nephrotic syndrome and glomerular disorders in children. Our speakers today are Dr. Agnes Trautman and Dr. Marina Vivarelli. Dr. Trautman is a pediatric nephrologist at the University of Heidelberg in Germany. She coordinates the clinical POTONET registry for primary steroid-resistant nephrotic syndrome in childhood. She has co-chaired the IPNA guidelines for steroid-resistant and steroid-sensitive nephrotic syndrome and the European Rare Kidney Disease Network Working Group on Hereditary Glomerulopathies. Dr. Vivarelli is a pediatric nephrologist and heads of the Laboratory of Nephrology and the Clinical Trials Center of the Bambino Gesù Children's Hospital in Rome, Italy. She has also co-chaired the IPNA guidelines for congenital nephrotic syndrome, steroid-resistant nephrotic syndrome, steroid-sensitive nephrotic syndrome, and IgA nephropathy and vasculitis, as well as the KDIGO guidelines on glomerular diseases. Drs. Trautman and Vivarelli have longstanding research interest and extensive expertise in the management of glomerular disease in children. Their talks today, they will focus on the practical application of the latest guidance from IPNA and KDIGO on management of nephrotic syndrome. We will start with Dr. Vivarelli. Thank you.
Thank you very much, Michelle, for your kind introduction, and good afternoon or good morning to you all. I will start by talking about the management of the steroid-sensitive forms of nephrotic syndrome, and I will give a broad overview of some of the most important aspects that are covered in the guidelines, comparing and contrasting the IPNA and the KDIGO guidelines. So steroid-sensitive nephrotic syndrome is the most frequent glomerular disease of childhood. It has an incidence of about 1.15 to 16.9 per 100,000 children per year globally. And we know that the vast majority of these forms are steroid sensitive. About 85 to 90% of the children will respond to a standard course of oral glucocorticoids. However, about 70 to 80% of those will show at least one relapse during follow-up. So this is a relapsing remitting the disease that can last for decades. And about half of the children affected by it will experience frequent relapses or become steroid dependent. And these are patients, therefore, that will require some form of long-term immunosuppression that needs to be given for years, sometimes occasionally also for decades. And unfortunately, those are the patients, about 10 to 30% of the initial group, who may continue to show relapses even as young adults. So when we're thinking about how to manage this disease, we really have to consider that, yes, it may not be a disease that will lead to terminal renal failure, but it is a disease that often has a lot of morbidity related to the treatment. So when we were thinking with the group of experts for the guidelines of how we wanted to tackle the optimal management of steroid-sensitive forms of nephrotic syndrome, we all agreed that the aims of this particular disease for management were treat to target. They were to achieve freedom from recurrence, but at the same time, to minimize the side effects of the management of the treatment options that we were choosing, and to maintain a good quality of life, allowing children with steroid-sensitive nephrotic syndrome to have essentially a normal life. And we also wanted to be well aware, since we wanted these guidelines to be applicable in different settings, of the different resources in different parts of the world, and therefore to provide guidance that is relevant in different settings all over the world. So let's start with the diagnostic workup. And here I'll go quickly because you all know how we define nephrotic syndrome. I just wanted to highlight some peculiar aspects of how we wrote it for the purpose of the guideline, both in the IPNA and the KDIGO ones. First of all, we decided that when you're talking about protein to creatinine ratio, and when you're talking about how to detect proteinuria, you can do it in the first morning void, because in pediatrics, it's really almost impossible in the smaller children to collect a 24-hour. And there is evidence showing that the first morning void and doing a ratio of protein to creatinine is, very, very similar and reproducible result that can clearly and unequivocally diagnose nephrotic syndrome. syndrome. We would like at least once the proteinuria to be confirmed by a laboratory analysis. And we know that this cutoff that we've given, which is the classic cutoff of above 200 milligrams over millimolar, 2 milligrams over milligram in the first morning void of urinary protein over creatinine ratio, corresponds to 3+ or 4+ by urine dipstick. And this, so the presence of nephrotic range proteinuria has to be accompanied, if you can perform a blood exam, by hypoalbuminemia with serum albumin below 30 grams per liter, or if you cannot, by the presence of clinical signs of edema. So one of these two, plus the nephrotic range proteinuria, allows you to diagnose nephrotic syndrome in a child. When you have this, sure, you need to take a careful patient history, a careful family history, careful physical examination, looking in addition to edema also for blood pressure, extrarenal symptoms, dysmorphic features, and abnormal external genitalia. You need to perform the urinalysis, at least one laboratory exam, in addition to a dipstick, which you might have performed in an emergency setting. And if you can, it's useful to perform blood exams. And the blood exams, the basic ones, are complete blood count, creatinine, eGFR, urea, electrolytes, albumin. Then if the patient has macroscopic hematuria, it's important to perform C3, C4, antinuclear, and anti-streptococcal antibodies. If AKI is present, it's important to perform ANCA dosage antibodies as well. So, and this is relatively not controversial. What can be a little bit more tricky is when and in what type of patient with a childhood presentation of nephrotic syndrome to perform a kidney biopsy. So, in a very small child below the age of 1, we're not talking about congenital nephrotic syndrome. So the 3 to 12 month age range, it's recommended to consider genetic testing and/or a kidney biopsy. And Agnes Troutman, in her talk, will talk about this a little bit more. So instead, in the ages above 1 year, it is not recommended to routinely perform neither kidney biopsy nor genetic testing. And so with this point, we come to the first polling question that I'd like you to answer for me. So polling question 1 is, when do you perform a kidney biopsy in a child with nephrotic syndrome who is older than 1 year of age? So would you perform it if the patient is non-responsive to 4 weeks of oral prednisone at standard dose? So if he's steroid resistant, or if the patient is above 12 years of age, or if the patient is above 15 years of age, or if the patient has atypical features like hematuria, low circulating C3 and or C4, AKI without hypovolemia, or systemic features like cutaneous rash or arthritis. And you can give more than one answer to this question. So I'll give you just a few seconds to respond. Okay, so the vast majority of you indicated that for him or her, the most important thing to indicate a kidney biopsy is the presence of atypical features. And about half indicated also the fact of being steroid resistant, whereas the age seemed to create more uncertainty. And this is very appropriate, and I'll try to explain to you a little bit why. So in the KDIGO guidelines, it is recommended to perform a kidney biopsy in children with nephrotic syndrome who are above or equal the age of 12. And in the IPNA guidelines, again, it is not recommended, but suggested to consider a kidney biopsy if the child is above 12 on a case-by-case basis. Now, why is this? I mean, obviously, the atypical features are a clear indication, as is the presence of steroid resistance. But in terms of age is an important factor. And this image from a recent review published in The Lancet can give you an idea why. So we expect that steroid-sensitive nephrotic syndrome is going to be mainly underled by minimal change disease. And if you look over age, this is the yellow part. If you look over age and the percentage of patients who will have that diagnosis, you see that, you know, in childhood, you really have a vast prevalence of minimal change disease. When you get to the age of 12, about 30%, a little bit more, will have other diagnoses, FSGS, membranous, and other histological diagnoses. When you get to 15, other diagnoses are about 50%. So you do have to start thinking about performing a biopsy regardless of the presentation above the age of 12, and you really should perform one at the age of 15. But in terms of recommendations, what we felt we could say was that we recommend patients diagnosed with steroid-resistant nephrotic syndrome. Last point here, we recommend in patients with atypical features, and we say to consider above the age of 12 on a case-by-case basis. We also added a caveat for populations from East Asia. Given the extremely high incidence of IgA nephropathy, we said to consider a biopsy if the patient also had persistent microscopic hematuria, which we know that can be found, but it is not so usual in the classic nephrotic syndrome that we are thinking about when we talk about childhood nephrotic syndrome. So primary immunosuppressive treatment, so how to treat the first episode, is very uncontroversial. So the only slight controversy is the duration of the treatment. So we start with a full dose of oral prednisone or prednisolone, 60 milligrams per square meter. And then we progress after 4 or 6 weeks of this treatment to 4 or 6 weeks of alternate day oral prednisone at 40 milligrams per square meter. And between the two schemes of 4 plus 4 weeks or 6 plus 6 weeks, it is at the moment impossible to choose because both seem to be equally useful and effective, even in terms of preventing further relapses. It may be a good idea to think that perhaps in smaller children who take longer to respond, it may be useful to give a slightly longer course compared to the 4 plus 4 can be kept for slightly older children who tend to have a better prognosis if they respond, especially if they respond very quickly. We don't really know this. This is just something that can be reasonable to consider. Monitoring during the acute phase and follow-up. One of the things that we really wanted to underline to bring this to the attention of everyone is the importance of regularly performing the dipstick at home to monitor relapses and to monitor how long it takes the patient to respond. So we recommended educating families and teaching them how to perform the dipstick. In settings where the dipstick is not available, the heat coagulation or sulfosalicylic acid test can also be performed, and in the supplemental material of the IPNA-SSNS guidelines, it gives indications of how to perform this. In terms of timing, it should be performed, the urine dipstick, at home daily until remission. Afterwards, at least twice weekly, at least for the first year. And it should again be performed daily, either if the child has evidence of proteinuria to see how fast it progresses and if the child needs to be treated again because it's a full-blown relapse, or during episodes of fever, infection, other triggers who can give a relapse, or in the presence of edema, which indicates probably that you haven't done the dipstick in a long time and you do have a relapse. The first-line therapy of a relapse. Even here, luckily, we have high-quality evidence, so there's not much controversy. We did introduce a new definition when we were talking about relapse. The classic definition of relapse is remained the same. It means that the proteinuria is again in the nephrotic range with or without edema, because hopefully we catch it much earlier this time because we're doing the dipstick at home. So even just 3 consecutive days of dipstick is enough to say, okay, this child has a relapse. We introduced the concept of complicated relapse because some children seem to take it harder when they relapse. And if they have a relapse that requires hospitalization with severe symptoms such as symptomatic hypovolemia, AKI, thrombosis, or a severe infection, that's different from a child who remains at home and is well. And this child, the child with a complicated relapse, may be a child in which you can think about introducing more precociously a steroid-sparing agent because the relapse is particularly aggressive and difficult for that specific child. The relapse is always treated with the same high dose standard of oral prednisone until the dipstick becomes negative or trace for at least 3 consecutive days, after which you can give 4 weeks of alternate day standard dose prednisone. We do not recommend at this stage a tapering schedule because it has not been shown to be more effective in preventing relapses. Another thorny issue that we tried to address in the guidelines was what to do if a child with nephrotic syndrome has an intercurrent infection, which we know to be a trigger of relapse. So in this case, what would you do? Polling question number 2, in a child with SSNS and an intercurrent upper respiratory tract infection, would you prescribe low-dose daily prednisone to prevent relapse? And you can answer either yes, always, no, never, if the patient is already on low-dose alternate day prednisone, or if the patient has a history of repeated infection-associated relapses. And here you can choose only one answer. Okay. See how you've responded. So slightly more than half of you have responded if the patient has a history of repeated infection-associated relapses. And 12% yes always, 13% no never, and 21% if the patient is already on low-dose alternate day prednisone. So this is interesting. And it mirrors what we have indicated. And also the fact that a lot of physicians around the world feel comfortable doing this. So in reality, there were some slightly lower quality randomized control studies showing that this seemed to be a correct approach. But then the PREDNOS 2 study was published in 2021 after the KDIGO guidelines had been published, showing that in reality, there was not much evidence for this type of behavior, because data indicated at the risk of relapse in a child with an upper respiratory tract infection and nephrotic syndrome, giving daily oral prednisone did not cross 1 in terms of the 95% confidence interval. So it did not prove clearly beneficial. However, it was argued in subsequent sub-analyses and discussion among experts that in children who really invariably tend to relapse, or in children who are already on alternate day oral prednisone, it really doesn't change very much. Therefore, the revised version of the KDIGO guidelines and the IPNA guidelines, and these two will mirror each other, say that we do not recommend the routine use of a short course of low-dose daily prednisone at the onset of an upper respiratory tract infection to prevent relapses. However, we suggest considering this short course, so it's only 3 extra doses of low-dose daily prednisone in a child with nephrotic syndrome and an upper respiratory tract infection if the child is already on alternate day oral prednisone and he or she has a history of repeated infection-associated relapses. And again, this is also going to be mirrored in the new version of the chapter of KDIGO on childhood nephrotic syndrome. So what about second line? So the second line is another particularly thorny issue, and I'm going to start with a scenario to show you some of the difficult points. So we have a little girl who's 9 years old. She had an onset of nephrotic syndrome at age 5. It was steroid sensitive. And in the following 3 years, she only had 1 relapse following vaccination. So she did really well. She had infrequently relapsing nephrotic syndrome. However, then in the last year, when she was 9, she had 2 relapses in 6 months, treated as recommended, followed after 3 months by a 3rd relapse. So 3 relapses in 12 months. So when we look at the amount of prednisone that this child has received, we see that her cumulative dose of prednisone, shown on the right-hand side of the slide, treating all these different relapses, is higher than if we had treated the first relapse and then given low-dose maintenance prednisone, which hopefully could have prevented the subsequent relapses. And when we're thinking about how to manage these children optimally, what we want to avoid is to have a high cumulative dose of prednisone. So to address this, we modified slightly the definitions in the IPNA guidelines, and we defined infrequently relapsing as having less than 3, so not more than 2 relapses in any subsequent 12-month period, and less than 2 in the first 6 months following the initial episode. And so frequently relapsing becomes a child who has at least 2 in the first 6 months, and at least 3, only 3 are sufficient to define frequently relapsing in a period of 12 months. So this child already would have fallen into the definition of frequently relapsing. We did not modify the definition for steroid dependent. And this modified definition of frequently relapsing was done in order to address probably the most pressing issue in these children, the minimization of the glucocorticoid-related toxicity, which we know to be so unpleasant and so detrimental in the long term. So in general, we also introduced some other definitions to try to define better what we intend by an optimal management. So sustained remission is no relapses over 12 months with or without therapy. But we also introduced a definition of controlled on therapy, which means that it's not that the child never relapses, because we recognize that this may be a little bit unreasonable and excessive. We don't want the child to never relapse, but we want the child to be infrequently relapsing, so to not relapse more than twice in a year. And we also want this to be achieved without significant drug-related toxicity. So if we obtain this, we say that our child is controlled on therapy and we're doing well. If our child is not controlled on therapy, which means that he has more than 2, and/or if he has significant drug-related toxicity, even though he only has 2 relapses a year, we need to do something different. And we defined very precisely the steroid toxicity with numerical indices of all the different steroid-related side effects. So in non-controlled on therapy, we should think of introducing a steroid-sparing agent. So we recommend to use maintenance treatment in all patients with frequently relapsing or steroid-dependent nephrotic syndrome. And we have a table where we looked at all these different agents. But in frequently relapsing, we also recognized that as an alternative to introducing a steroid-sparing agent, it can be fine to use low-dose maintenance prednisone. And instead, we absolutely have to use a steroid-sparing agent and not low-dose maintenance prednisone if the child is not controlled on therapy, or if the child has suffered from a complicated relapse, so a relapse requiring hospitalization, or if the child is steroid dependent. So when we're thinking about which steroid-sparing agent choose, this is the KDIGO guideline, where we had differentiated between frequently relapsing and steroid-dependent forms, because the evidence for cyclophosphamide and levamisole in particular is much better for a frequently relapsing compared to a steroid-dependent child. So going back to our scenario, our child who had frequent relapses was given 2 options: either low-dose maintenance with oral prednisone alone, or levamisole, which is given in alternate days, in the beginning with prednisone and then alone. What happened to this child was that she started levamisole, initially with low-dose oral prednisone, then alone. But 6 months later, she relapsed again. But not only, at this point, she was 10, her BMI was elevated, 27, and she complained about her inability to lose weight. So she had the number of relapses to say that she was controlled, but she was experiencing significant steroid toxicity. So at this point, she was not controlled on therapy. So polling question number 3, in a child with this type of a picture, frequently relapsing nephrotic syndrome, not controlled on levamisole, which steroid-sparing agent would you now choose? Mycophenolate mofetil, cyclophosphamide, a calcineurin inhibitor, or rituximab, and you have to choose one. So it's interesting to see, and this absolutely reflects what we saw during the IPNA guidelines when we were discussing between the different experts, that there's a spread, and there isn't a clear winner here. And this is exactly what, in our discussions with the experts, we saw, and it also accurately reflects the lack of randomized controlled trials comparing one agent versus another. So in the selection of steroid-sparing agent, based on this, the IPNA guidelines said that the agent must be chosen after a careful discussion with the parents of the child or caregivers, and the child him or herself is old enough, looking at the efficacy but also at the side effects as listed in the table. And we put the agents in alphabetical order because we truly could not choose one. However, we did leave out rituximab. So at this point, if we look at the algorithm, we have introduced a steroid-sparing agent, we monitor the child, and we see how it goes. If the patient is controlled on therapy for more than 12 months, then we should taper. Because we also have to remember that the side effects must not accumulate, and all of these drugs have side effects. So at 12 months of a child who's been well controlled on therapy, we should consider tapering and discontinuation of whatever maintenance treatment that child is on. However, the child is not controlled on therapy, then we introduce the concept of switching and using another agent. And we considered rituximab as probably the best second line of steroid-sparing agents. But we said that at this point in time, with the evidence that we have for rituximab, we thought that it was more prudent to choose it not as a first-line steroid-sparing agent, but in a child who has already failed at least one other steroid-sparing agent given at adequate dose. And that this was probably particularly true in the younger population that tends to respond less well to rituximab. We then indicated the recommended dosage, number of infusions. Unfortunately, there's no evidence. And we gave a series of recommendations, which for the sake of time, I will now not cover, on how to monitor the child on rituximab. And last, what do you do when you run out treatment options? So scenario of a little boy, 9 years old, with an onset at 3. In the following 3 years, frequent relapses despite treatment with oral prednisone and CNI, switched at age 6 to MMF, rapidly relapsed at age 6 and 4 months, received a first rituximab infusion with rapid tapering of MMF and prednisone. After 6 months, again, relapsed, received a second and third dose of rituximab. But at age 9, his BMI is 29, his height at 25th percentile, so he's experiencing significant steroid toxicity, and he still has relapses. So these are the most difficult patients. Unfortunately, we don't have a lot of evidence for what to do. The things that we can recommend at this point in time with the evidence that we have is to consider enrollment in available clinical trials and to consider combination of steroid-sparing agents. The best quality evidence for combination is rituximab with mycophenolate mofetil, and this will be addressed in the new KDIGO chapter that will be soon published. So with this, I'd like to conclude. I'm sorry I went slightly over time, acknowledging all the experts who contributed to the IPNA guideline, which was a major effort, and also all the colleagues and the evidence review team that contributed to the KDIGO guideline chapter that I wrote together with Keisha Gibson. And I'd like to thank you for your attention, and you can email me for further questions.
So hello, everyone. It's my great pleasure to speak about the latest guidance on SRNS today. Okay, and thank you, Michelle, for the kind introduction, and also thank you for the great overview, Marina. So from your talk, I will really benefit from my presentation in SRNS. So to start with the challenges in steroid-resistant nephrotic syndrome, it's a rare disease. You've heard the incidence of overall idiopathic nephrotic syndrome, and SRNS represents only 10 to 15% of all idiopathic nephrotic syndrome in childhood. And the clinical management is challenging due to an heterogeneous etiology. The disease courses are highly variable, and of course, high disease and treatment-related comorbidity. So far, there are multiple treatment strategies used, but unfortunately, there's really a lack of high-quality evidence. So that is in contrast to steroid-sensitive nephrotic syndrome. So when we performed the evidence review, we have only found 27 RCTs since 1970. There are more observational studies available. These are the two main etiologies of SRNS. So the monogenic forms in up to 30% of patients with the structural anomalies of glomerular filtration barrier, so with a genetic mutation in a podocyte-associated gene. And the other patients are immune-mediated diseases with a so far not specified circulating permeability factor disease. So KDIGO and IPNA developed a clinical algorithm for the disease. Marina has shown you already the algorithm from KDIGO. KDIGO, I can reassure you that the KDIGO and IPNA clinical practice guidelines are generally the same recommendations. So there are no really differences in steroid-resistant nephrotic syndrome. The IPNA guidelines is more detailed, of course, because it's a concentrate only on steroid-resistant nephrotic syndrome. But in general, they are very similar, both guidelines. And in the next slide, you will see the algorithm from the IPNA guideline. I'm waiting for changing the slide. So far, it's not working. Ah, yes, here it is. So here you can see the algorithm for SRNS from the IPNA guidelines. It looks quite complicated. You can have a look for the details in the guideline itself. Due to the limited time, I will show you only some aspects of the guideline based on a case presentation. Yes, so that's the case. So Paul is a 5-year-old boy and he's seen in the nephrology clinic 4 weeks after his initial presentation and after treatment start with prednisolone at standard doses. As Urina recommended from the guidelines of steroid-sensitive nephrotic syndrome, the parents have monitored the proteinuria at home with dipsticks and it still shows 3+ proteinuria. Paul is doing well, edema has been resolved, blood pressure is normal and he's having a very good appetite on prednisolone. And the blood and urine tests show normal electrolytes, normal renal function, the serum albumin of 29, and the urine protein creatinine ratio of 450 milligram per millimole. So what do we see here? So we are seeing here a hypoalbuminemia and nephrotic range proteinuria, and that is a definition for no remission so far. And at that point, I would like to highlight that we recommend the dipstick protocol at home. But if you want to evaluate the treatment response and if you want to base this treatment decision on the results, then we recommend to quantify the proteinuria in the lab, for example, by the urine protein creatinine ratio. Oh, now it was too quick. So now it's my question to you. We have now a steroid-resistant nephrotic syndrome, and I would like to ask you which of the following is not the most appropriate next step for further diagnostic evaluation and management in Paul's case. A, kidney biopsy. B, genetic screening for hereditary podocytopathies. C, continuation of prednisolone 60 mg per square meter per day for another 6 weeks. D, consider administration of 3 methylprednisolone pulses optionally. Or E, initiation of RAS inhibitor therapy. So please choose your answer, which is not the next appropriate step. Okay, very good. So 63% indicated that you would not continue prednisone in the high dose for another 6 weeks. Okay, thank you. So then we will continue. So here's the aspect from the clinical algorithm from the IPNA guideline that we introduce a new time period, the confirmation period. So this is the time period between 4 and 6 weeks after starting prednisolone treatment. And why do we suggest to introduce the new term at the time period? The background is that most pediatric nephrologists consider a child steroid resistant after 4 or 6 weeks. However, there is no universal consensus on the minimum duration of daily steroid exposure. And we know that almost 95% of children achieve remission within the first 4 weeks. And given the fact that a small percentage of children achieve remission within 2 additional weeks of daily prednisolone treatment, or by using 3 pulses of methylprednisolone, we decided on the additional time window of 2 weeks, and we called it confirmation period. And this confirmation period is also used to initiate RAS inhibitor therapy and to perform genetic and/or renal biopsy. Why do we suggest to start already early non-immunosuppressive treatment with RAS inhibition? So we know from larger studies in CKD patients and small RCTs in SRNS patients that RAS blockade is able to reduce proteinuria dose-dependently by 30 to 50%. And another aspect of starting RAS early and before of the next immunosuppression is to differentiate the antiproteinuric effect of RAS from the effect of immunosuppressive drugs later on. And when using RAS inhibition, of course, be cautious if there is recurrent hyperkalemia, if there's initial CKD, or there's an intravascular volume depletion. the next step is to differentiate genetic disease from non-genetic SRNS. And here we recommend, if available, that genetic testing be performed in all children with primary SRNS, except in patients with secondary cause or with initial steroid sensitivity. And we suggest giving priority to genetic testing in familial forms, in children with extrarenal features, especially if they are very young, and pre-renal transplant. And we also suggest genetic testing before a kidney biopsy, especially in the priority cases, provided the results will be readily available within a few weeks. Of course, if this is not possible, then you will start immunosuppression and then you will re-evaluate the situation after receiving the genetic results. And that genetic matters on renal prognosis, we know from outcome studies. So genetic diagnosis has really an impact on the renal prognosis with a much more higher risk for progression to ESKD than in patients who are having sporadic disease and responding to immunosuppressive therapy. So that's why it's important to identify the monogenic SRNS. And given the likelihood of non-responsiveness of patients with a structural defect in the glomerular filtration barrier also, it's necessary to know to withdraw ineffective or harmful therapy. Harmful therapy, I'm thinking of, for example, SMARCL1 patients who are having immunodeficiency and are at increased risk for infections on immunosuppression, or to provide specific treatment when available, for example, in coenzyme Q10 supplementation in patients with CoQ10 deficiency. And as I've shown you, to provide an estimate of the risk of ESKD and of the risk of post-transplant recurrence, which is lower than in immune-mediated forms. And also to allow screening for dangerous comorbidities, for example, for nephroblastoma or gonadoblastoma in WT1 patients, and to provide family counseling about the prognosis of the disease. The frequency of genetic SRNS per age group decreases by age. The most common podocytopathies in childhood are patients with NPHS1, NPHS2, and WT1 patients. Also within the confirmation period, we recommend a kidney biopsy in all children, except what we have just discussed in patients with already confirmed genetic disease or in patients with familial or syndromic cases waiting first for the genetic results, and except in known infections or malignancy-associated secondary disease. Why to perform renal biopsy? So to exclude rare cases of other glomerular disorders presenting as SRNS, like IgA nephropathy, membranous nephropathy, Alport, C3 glomerulopathy, SLE, TMA, and amyloidosis. And of course, also to confirm primary podocytopathy. So the most common histopathologies are minimal change disease, FSGS, and diffuse mesangial sclerosis, as well as to evaluate the glomerulosclerosis grade and to general status of kidney fibrosis. And also when you're already treating with CNIs, to follow the CNIs to assess for CNI-induced renal damage. So how is it going in Paul's case? So Paul's NGS panel sequencing of all currently known SRNS genes turned out negative, and the renal biopsy showed an early stage of FSGS. His clinical condition has been improved and ramipril was started. And after starting of ramipril, the proteinuria was assessed, and it was a mild reduction, but still a nephrotic range proteinuria. And the serum albumin remained low between 27 and 29. So in summary, Paul has been diagnosed with a sporadic, non-genetic SRNS requiring further immunosuppressive treatment. And in the next question, I would want to show you that not only genetics, but also the treatment response can predict renal prognosis. So we know from short-term and long-term studies that the renal outcome is very favorable in patients who respond to immunosuppressive treatment with a 10-year renal survival probability of 97%, whereas patients who do not respond to immunosuppression have a progression to ESKD of 60%. So as you can see, it's very important to induce remission. And I would like to ask you, which of the following drugs are you using as first-line immunosuppressive treatment in non-genetic SRNS? So please choose your option. It's A, MMF, B, cyclophosphamide, C, SNIs, D, rituximab, or E, methylprednisolone pulses. Okay, thank you. So most of you, 72%, are using calcineurin inhibitors. How was it done in Paul's case? So Paul was also started on tacrolimus. And this is also the first recommendation of IPNA and KDIGO guideline to use SNIs as first-line treatment. There are mild differences in the recommendation for the starting dose and the individual trough levels, but both guidelines say that it's important to perform drug monitoring, so monitoring the trough levels to prevent side effects by adequate but minimal dosing of CNI. So given the fact that a variable proportion of patients respond to CNI within a few weeks to months, we suggest a minimum treatment period of 6 months to determine the response to CNI. Of course, to withhold or delay the treatment if the eGFR is below 30, if there's acute kidney injury or uncontrolled hypertension. And we also recommend making parents and families aware of potential side effects. At this point, I would like to highlight that a prolonged routine treatment with prednisolone in conjunction with CNI and RAS inhibition is not beneficial, but may cause steroid toxicity. So therefore, we do not recommend prolonged treatment, and we suggest tapering prednisolone and discontinuing after 6 months. In individual cases, this can be also discontinued a little bit or quicker. So in Paul's case, this was done. Prednisone was reduced, and a tapering scheme was planned over the next 6 months, and ramipril treatment was continued. The optimal case would be if the CNI response at 6 months is a complete remission. In this case, then the aim would be to maintain the remission and to avoid nephrotoxicity and side effects. And for that, we suggest to reduce CNI dosages to the lowest dosage required to maintain remission, performing the trough level monitoring. And if the patient is still in remission after 12 to 24 months, consider to discontinue or alternatively consider a conversion to MMF to maintain the remission. If the patient is not responding to CNI within 6 months, so if there's an absence of at least partial response to CNI after 6 months of treatment at adequate doses and or levels, then KDIGO and IPNA guideline defines the SRNS as CNI resistant. And in the following, there are not many evidence what to do then. So we suggest to discontinue an ineffective treatment CNIs, and if there's a clinical trial available, enroll the patient into the trial. If not, then you can consider to administer rituximab. And if there's still no remission after 12 months, then KDIGO and IPNA define the patient as multi-drug resistance, so an absence of complete remission after 12 months of treatment with 2 mechanistically distinct steroid-sparing agent at standard doses. And then in the next, it's more clinical experience, because there are no really data, only case series and small observation studies. Then you can consider to use ofatumumab if available, or plasma exchange, or immunoadsorption, or lipid apheresis. Let us see how it's going in Paul's case. So Paul's response to CNI at 6 months was showing a UPCR of 175 milligram per millimole and a serum albumin of 33 gram per liter. And if you think the definitions, then you will see that a non-nephrotic range proteinuria plus albumin above 30 is a partial response after 6 months of tacrolimus. So in this case, having partial remission after 6 months of CNI treatment, I would like to ask you in the next slide, how would you proceed with the treatment? A, stop CNI treatment. B, continue CNI for another 6 months and consider to optimize RAS inhibitor therapy. C, continue CNI combined with prednisolone for another 6 months. D, switch to MMF, or E, switch to rituximab. Okay, thank you very much. So more than a half of you continue CNI for another 6 months and consider to optimize RAS inhibitor therapy. And 20% would switch to rituximab, 12 to MMF. Yes, okay. And stopping treatment is not really considered. Perfect. So if a patient has not responded to CNI within 6 months, but has a partial remission, there's still the chance that the patients can respond. So for example, here in Paul's case, tacrolimus was continued at unchanged doses, ramipril was increased, but in his case, unfortunately, the partial remission was not of long duration, and he developed again nephrotic range proteinuria and serum albumin dropped again. So I can show you this also in the algorithm. So here we have a no remission after 12 months of treatment with tacrolimus, and is defined as a CNI-resistant nephrotic syndrome. Here is this seeing in the algorithm. So if you have CNI response of partial remission at 6 months, then we suggest to continue CNI at initial dose. And if you then have a complete remission after 12 months, then it's clear, follow the way with minimization of CNI dosage to maintain remission. If you have no remission, then it's defined CNI-resistant nephrotic syndrome. A very difficult question was in our discussion within the guideline meetings, how to proceed with a patient who are still having partial remission after 12 months of therapy. And in this situation, unfortunately, we cannot give any recommendation or at least a suggestion because there are absolutely no data about that. So here we suggest it will be an individual decision, and in your clinical experience and your clinical center experience, CNA may be stopped or continued, whatever the patient benefit from. So how it's going in Paul's case. So unfortunately, there was no trial available, and rituximab was given and was discussed with the parents. However, despite rituximab treatment, complete B-cell depletion, and overlapping tacrolimus treatment, Paul continued to have nephrotic range proteinuria. So unfortunately, he was diagnosed with multi-drug resistant nephrotic syndrome. And he unfortunately suffered from several infection hospitalizations in the further course, and the parents were counseled, and tacrolimus were tapered, then slowly and finally discontinued, and the non-immunosuppressive management was continued. So, as I already told you, it is very important to differentiate between non-genetic and genetic SRNS. So we recommend that screening for all known podocytopathic genes be offered to enable decisions on further immunosuppression if available. And given the likelihood of non-responsiveness of patients with structural defects in the glomerular filtration barrier to immunosuppression, we recommend withholding CNI and stopping prednisolone treatment in patients with monogenic form of SRNS. So the most difficult question remains open: when to withdraw immunosuppressive agents. So in genetic patients, we agreed on what I've told you, that we suggest to discontinue the ineffective treatment in genetic forms, also as well in non-responsive non-genetic patients with multi-drug resistant immunosuppressive forms. And in those cases, the focus of treatment should be to optimize the non-immunosuppressive and supportive management in order to slowing down the progression to renal failure. But what to do in the patients who are reported having partial or complete remission immunosuppression? So you might know that there are very few cases reports published of genetic patients with partial remission or transient complete remission on immunosuppression. What all children had in common is that they have been treated with RAS inhibition and CNIs, which may stabilize the podocyte actin cytoskeleton. However, our experience from registry studies shows that almost all had only a transient remission and progressed to ESKD soon. And the question how to proceed in those children is very difficult. And in those cases, we recommend to review the pathogenicity of the genetic variant and evaluate the duration of remission, what I've told you. And then to assess the benefit of potential partial remission, so for example, symptomatic relief and potential lower risk of disease progression, versus the potential risk, treatment-related toxicity, infections, anything. And always the final decision should be made in the clinical team together with the family. But that's really an assessment of benefits and risk. So I hope you were able to gain an impression of the IPNA and KDIGO clinical practice recommendation by picking out a few aspects based on a case report. You will find much more details in KDIGO and IPNA guideline. And we hope that the algorithm will help in the diagnosis and in the challenging clinical management as a first step in a work in progress. But especially in SRNS, further adequately powered clinical trials, including untreated controls, are needed. And both guidelines, KDIGO and IPNA guideline, provides a recommendation for future research. So at this point, I would like to thank you, the guideline group of the IPNA guideline, coordinated by Dieter Hafner, as well as the guideline group of the KDIGO Childhood Nephrotic Syndrome chapter. And I would like to thank you for your attention and send best wishes from Heidelberg in Germany.
Thank you both for those really comprehensive talks. There have been some questions in the Q&A that I know some have been addressed with written responses, but I'll start with, there were several questions pertaining to the therapies used in frequently relapsing and steroid-dependent nephrotic syndrome, particularly around tapering of steroid-sparing agents. So I'll start by posing that question in terms of how to taper a steroid-sparing agent, which I know is a complicated question and agent-dependent.
Yeah, thanks, Michelle. That is a difficult question, and there is absolutely no evidence to guide us because, to the best of my knowledge, this has never been looked at in a controlled fashion. However, when you're tapering glucocorticoids in many diseases, we tend to taper very, very, very gradually. When you're using a steroid-sparing agent, such as mycophenolate mofetil or a calcineurin inhibitor, which is what I imagine is the main target of this question, I can just give you my expert opinion. If it's a patient that I'm a little bit concerned about, I tend to taper in about 2 or 3 months. If it's a patient that I'm not worried at all about relapsing, I might do it even shorter, in about 4 weeks. I have gone into super obsessive phases in which I've tapered more slowly, but I've never tapered in more than 4 to 6 months. I would recommend, if your child has been stable with either sustained remission or not more than 2 relapses in the last 12 months, you have to give him or her a chance to prove that he's actually doing better, especially if he's post-pubertal. I would recommend tapering quite rapidly. If the patient is peripubertal and you're a little bit more nervous, then perhaps you can taper a little bit more slowly. But in general, it doesn't really make sense to taper a steroid-sparing agent particularly slowly. And definitely in the 95% of cases, it would not make any sense to taper in more than 3 months, in my opinion.
Thank you. I think relatedly for rituximab, there were some questions both about maximum dosing, and I think this was getting at cumulative dosing. So over, as you mentioned, what can be decades of dealing with a complicated nephrotic syndrome. So there was a question about maximum dosing, which I believe is unknown, and about safety monitoring, particularly around immunoglobulin screening.
Okay. Thanks, Michelle. So as far as the maximal dose, and so the number of infusions, the number of times that you can repeat rituximab, there is no evidence. There have been cases in which rituximab has been repeated a lot. In general, what I would suggest is that if you find yourself over the course of, 5, 6, 7 years needing to repeat rituximab very frequently, it means that it's not the right therapeutic agent. A patient who's benefiting from rituximab should be able to not infuse it more than once a year, I would say, optimally even less frequently. And so I would consider other therapeutic options if that patient is requiring such frequent repeated infusions, or the combination of rituximab, for example, with mycophenolate mofetil, which is shown to be very effective in a randomized controlled trial published by Ijima's group in Kidney International in prolonging and maintaining sustained remission. In terms of the things that you need to control, gamma globulins is one of the things, and in both Table 5 of the IPNA guidelines and a relatively similar table in the KDIGO chapter on nephrotic syndrome, there are indications of what should be checked to be on the safe side in these patients.
Thank you. There were also a couple of questions came in recently about adrenal suppression and when to be concerned and how to monitor for risk of adrenal suppression, particularly in the patient population that has been on frequent and prolonged courses of corticosteroids.
So even here, there is not a whole lot of evidence. There are a few studies that have tried to look at this. I would argue that, to me, if you're starting to get worried about adrenal suppression, you haven't been using the glucocorticoids according to the guidelines, because you really shouldn't give them for prolonged periods of time at higher doses that are able to suppress the adrenal gland. So when you're treating for the classical onset a scheme, you can definitely interrupt brusquely. Same with the scheme that is now recommended for relapse, which is full dose until 3 days of negative dipstick, 4 weeks alternate day, and then you drop it cold turkey. If you're using it for the maintenance for a frequently relapsing child who has no steroid-related toxicity, you're using it at such a low dose that even there you can interrupt it cold turkey and nothing is going to happen. So I would really advocate for not using high doses for prolonged periods of glucocorticoids with all the different options that we now have.
Thank you, and I'll pose this question to Agnes. There was a question about, is there a difference in the approach in management for the patient who becomes steroid resistant as opposed to who's resistant from the outset?
You mean the secondary steroid-resistant patients, I presume? Yes, so usually the secondary steroid-resistant nephrotic syndrome, so usually they are immune-mediated disease, and so far that's as I told you, no genetic testing recommended in the diagnostic first. So that would be the difference in the diagnostics.
Thank you. There's a specific question to Dr. Vivarelli. Does measuring the B-cell repopulation help decide when and how to dose rituximab?
Well, I mean, we've published on this, so it's something that I feel quite strongly about. So in the papers that we have published, and in particular, the evidences that we looked at, looking at different B-cell subpopulations, we believe that in reality, more than dosing total B-cells to predict relapse, which can predict relapse, it's measuring memory B-cells, which are a subset of the B-cell population that can predict relapse. So this may be useful to predict relapse, and we are looking for ways of making this much, much simpler so that it can be done in a routine setting all over the world. And this is something that I believe will potentially could make the use of rituximab much more tailored, much more effective, much less frequent, and much better overall. For the time being, in the routine clinical setting, looking at total B cell numbers can be an indication, but some patients will not reconstitute the memory B cells, and so they will not relapse, even though they have reconstituted total B cells. And we see this quite frequently.
Thank you. I will also combine a couple of questions that came through on cyclophosphamide. One is the lowest age at which it can be started for frequently relapsing and steroid-dependent nephrotic syndrome. And the second question is, what is your opinion on using IV versus oral cyclophosphamide?
So I'm probably not the best person to ask because I've never used cyclophosphamide for children with nephrotic syndrome. I have looked at the literature though, and in general, it is thought that it is better to use oral cyclophosphamide for childhood nephrotic syndrome compared to IV, even though IV can be used if there are compliance issues or other practical issues. The doses for both forms are given in both guidelines. But the important concept when you're using cyclophosphamide is that it has to be a limited period, a single cycle, and it must not go beyond the total cumulative dose recommended, because otherwise the toxicity of the drug becomes significantly greater than the benefit of using this drug. In terms of age, it is also a drug that can be used safely in the smaller children, and it actually there are some evidences that it might be preferable to use in smaller children that are further away from puberty, from a safety profile in terms of gonadotoxicity. Everything concerning the optimal use for cyclophosphamide, again, is indicated clearly in the Table 5 of the IPNA guidelines and the corresponding table of the KDIGO guidelines.
Thank you. Do we have more time for questions?
I can stick around for a little bit longer.
So this question has come up a couple times. I think you did type something in the Q&A, but I think the attendees are interested in SGLT2 inhibitors and the management of proteinuria, which this is a very heterogeneous population, and there really is no pediatric data. But if you would speak to their potential use.
So this is perhaps more for Agnes than for me. I would definitely say that there is little to no space for the use of an SGLT2 inhibitor in steroid-sensitive nephrotic syndrome. And we wish we had more evidence for steroid-resistant nephrotic syndrome, but I would be interested to see what Agnes has to say about this as well.
So to my knowledge so far, that is also not really evidence in patient. However, I think in clinical practice, because there's so great data from the adult nephrologist, several centers already use SGLT inhibitors when the proteinuria is not controlled despite an optimization of RAS inhibitor therapy. So for example, also we are using SGLT2 inhibitors already in patients, for example, with genetic disease, who are still having a nephrotic range proteinuria despite the highest RAS blockade. And we are seeing in the first patients quite a reduction of proteinuria. So we will see how it will develops, but yeah, hopefully it will have effect in those patients, a positive one.
Thank you. There's a question about do we need to prescribe calcium and vitamin D to prevent steroid-induced osteoporosis?
So overall, there is not enough strong evidence for us to recommend the use of calcium and vitamin D in children, in the setting of children with nephrotic syndrome, again, who optimally should not receive very prolonged courses or very high doses of glucocorticoids. So in the guidelines, we decided to not strongly suggest the use of these agents in this specific therapeutic setting.
I think this is the first question coming up about levamisole. Is there any concern about ANCA-associated vasculitis with levamisole use?
Yeah, so that's a really good question. And, we tried to push for levamisole because the evidence regarding levamisole, especially in frequently relapsing nephrotic syndrome, is really excellent. And it's been pulled from the market in many, many countries, but we really think that it would be good for this drug to be more easily available, especially because it's very, very inexpensive, but also has a very good safety profile. But what some people worry about is this ANCA issue. And in reality, when you look at the literature, the cases in which there have been cutaneous and arthritis manifestations are only cases in which ANCA levels were never checked. If you check the ANCA levels in a child with levamisole, even just annually, that can be more than enough to recognize the positivity of the ANCA and to interrupt the treatment with levamisole. It can be optimal in a setting which is, not too low resource to perform this control every 6 months. And with that, you're really very confident that you're not going to have any clinical side effect whatsoever, as long as you interrupt the levamisole if the ANCA become positive.
Thank you. Going more to the steroid-resistant nephrotic syndrome, some questions there. There's a question about if the steroid-resistant nephrotic syndrome is immune-mediated and there's a response with plasma exchange post-transplant, is there an argument for using this early after diagnosis rather than waiting until renal damage is established?
Do I understand correct to perform plasma exchanges before transplant or already during the conservative treatment?
I believe the question was, is there a role for plasma exchange in the pre-transplant management of steroid-resistant nephrotic syndrome?
So I'm assuming there are a few case reports in patients who are multi-drug resistant and in which where plasma exchanges were used or immunoabsorption or lipid apheresis. It has been shown that it can be in a multimodal approach to achieve remission or to improve proteinuria and to reduce proteinuria, but there's only very small observational studies and only case reports. So if it's a multi-drug resistant nephrotic syndrome and if you suspect it's really immune-mediated form, so we suggest in the guidelines to try an approach, but the data, so the evidence is quite low for all the other treatment options. That's why we think there are more trials necessary to do. But there's no preference to use immunoabsorption or plasma exchange or lipid apheresis or ofatumumab as a second line immunosuppressive treatment in SRNS.
And I think this is getting at complications. Do you measure thyroid hormone levels in nephrotic syndrome? And if low, I'm assuming meaning, if there's indication of hypothyroidism, do you give them thyroid hormone replacement?
That's something that we see only in the, sorry.
No, please go ahead. Please go ahead.
I was saying this is something that we see mainly in the setting of congenital nephrotic syndrome, and in very rarely in steroid resistant, they're rarely nephrotic enough for that to become a real issue, especially if you use ACE inhibition appropriately. But I would be curious to see if Agnes sees it in older kids with steroid resistant. In my experience, it's extremely exceptional outside the setting of congenital nephrotic syndrome.
No, that's true. So we are screening once a year in a patient who's not in remission. However, so far, I'm not aware of a patient who needs thyroid hormones in our clinic. So usually it's controlled, but we are screening it once a year.
And then, I'm sorry, I'm just scrolling through the questions. I think if, and I'm not sure, there's a question about experience with obinutuzumab. So maybe you could comment more just on the alternative anti-CD20 agents and the existing evidence.
Okay, so the alternative to rituximab are the biosimilar, which can be called Rixaton or have other names, but which still is rituximab. So, and it's an anti-CD20 that binds CD20 in the same place and in the same way as rituximab. And those are very similar in their effect and in their efficacy and safety. There's another humanized monoclonal anti-CD20 called ofatumumab, which has been used in nephrotic syndrome. And that was shown in a randomized controlled trial that was published in Kidney International to be equivalent but not superior to rituximab. In terms of obinutuzumab is a different type of anti-CD20 monoclonal antibody. It induces a more prolonged B-cell depletion because it acts with a different mechanism and it's complement independent, and its cytotoxicity is more powerful. And there is currently a trial that has been run, and there have been some publications of single cases in very aggressive forms of nephrotic syndrome where it seems to be very effective. We have to be very careful also of the potential toxicity of such an agent. And so I think for now, we don't have enough evidence to say that it's an agent that we can feel comfortable using. It can be perhaps considered in very severe patients who are refractory to other types of therapy.
So thank you everybody for joining. I know we didn't get to all of the questions, but our speakers today, I think, attached their email to the slides. The session is recorded, so please reach out with questions, and we hope it was informative for everybody. Thank you for joining today.
Thank you very much. Bye-bye.